Can you just close and open it once again?
Okay, okay, sir.
Okay, and you can start as soon as you open it because we are going live.
Yeah, okay, okay, sir.
Just close it once and then just share it once again. See, next to your battery percentage, yes, yeah.
Here only, no, sir. The usual slideshow part.
Yes, yes.
Now? Now you are able to see slideshow, sir?
No, we are not able to see. On top, there is one slideshow option. On the top, file edit somewhere there. Go to slideshow and start from beginning. Maybe you'll be able to get. Otherwise, you continue with this mode, but you'll have to scroll your sides from the slideshow slide sorter view only. If you click on the thing, it won't change.
Are you able to see the slide moving, sir?
You know, just
Are you
I
able to
can't see
see?
the slide. No, I'm still on this main the titles slide.
It's moving for me. Okay.
So go to the left where you are seeing all your other slides, and then from there you scroll. Then we may be able to see. The slide sorter sometimes is getting stuck in some of the older versions of Windows. I think.
Now, sir?
Yeah, now they are moving. Now it's moving.
Okay. Okay.
Let's do with this. I think that's all we can do.
Yeah, okay, sir. Fine. Good morning, everyone. So I'm Dr. Ranjana. I'm doing my DRMB second year at Medicover Hospitals. So today we are talking about the management of acute coronary syndrome, which is an evidence-based review today. So first, what is acute coronary syndrome? It encompasses a spectrum of conditions which includes patients presenting with a range of clinical symptoms or signs with or without changes on a 12-lead ECG and with or without acute elevations in the cardiac troponin concentrations. For example, the patient might present with mild symptoms or increasing chest pain symptoms, persistent chest pain symptoms. They can also present in shock, in failure, and also in cardiac arrest. So the ECG, which we do immediately after the patient comes, it can have a range of findings ranging from normal to ST segment depression to ST segment elevation to arrhythmias also. So basically, these patients, they go into the category of diagnosis as unstable angina or myocardial infarction. And among myocardial infarction, there can be non-ST elevation myocardial infarction or ST elevation myocardial infarction. So coming to myocardial infarction, there are basically 5 types. Type 1 is due to coronary plaque or rupture or erosion. Type 1. Type 2 is due to imbalance in the oxygen supply or demand without any evidence of coronary plaque. Type 3 is where cardiac death occurs with symptoms suggestive of myocardial ischemia, where the death occurs even before the biomarkers can be obtained. And type 4, there is type 4A, 4B, and 4C, where the infarction is related to previous coronary intervention. 4A is after PCI, 4B is due to any stent thrombosis, and 4C is due to restenosis. And type 5 is MI related to coronary artery bypass grafting. The fourth universal definition of myocardial infarction was formulated in 2018 and it was published in the Circulation Journal. where specific criteria have been given to identify myocardial injury and myocardial ischemia. So myocardial injury is the detection of an elevated cardiac troponin value above the 99th percentile of the upper reference limit. This injury is considered acute if there is a rise or and fall of the cardiac troponin values. Type 1 and type 2 MI, this detection of a rise or fall of the cardiac troponin value is required with at least one other of the following indications of an ischemia, such as symptoms of an acute ischemia or new ischemic ECG changes, development of pathological Q waves, imaging evidence of new loss of viable myocardium, or identification of a coronary thrombus by angiography. However, the last point will not apply for type 2 MI. In case of post-PCI MI, like type 4A, 4B, and 4C, the elevation of the cardiac troponin value should be more than 5 times in case of patients with normal baseline value. Suppose the patient has a pre-procedure high troponin value, the post-procedure value must be 20% above this value. And along with this, the patient should also present with at least one of the previous ischemic signs which I had mentioned earlier, or there should be an angiographic evidence which is consistent with the procedural flow limiting complication, such as coronary dissection or any occlusion of a major epicardial artery, any disruption of the collateral flow, or any distal embolization. In case of type 5 MI, that is CABG related MI, the elevation should be more than 10 times from if the patient is having a normal baseline. And if they have an elevated pre-procedure value, it should be 20% above that value. So in addition to this, they should also have development of new pathological Q waves or any angiographically documented new graft occlusion or new native coronary artery occlusion. What is unstable angina? Unstable angina is defined as myocardial ischemia at rest or on minimal exertion in the absence of acute cardiomyocyte injury or necrosis. So specific clinical pictures such as prolonged or more than 20 minutes angina at rest. Is there any new onset of severe angina, angina that is increasing in frequency, longer in duration or lower in threshold, or angina that tends to occur after a recent episode of MI? So moving on to the initial triage of these patients, it is always A, C, and S. Coming to the C first. C is clinical context. How has the patient presented? What is the type of chest pain? Is it chest heaviness, chest tightness? Is it burning kind of chest pain? Then this should alarm you to the possibility of an acute coronary syndrome. Other mimics can be epigastric pain or jaw pain or left upper arm pain. These are all like ACS mimics. Next, moving on to the S component, you have to check the vitals of the patient to classify whether they are hemodynamically stable or unstable, especially the patients who come in shock. And going on to A is abnormal ECG. ECG should be done within 10 minutes of the patient's arrival. And that has to give us an idea whether it is a normal ECG or whether it is an ST elevation MI or a non-ST elevation MI. So moving on to the diagnostic tool that is ECG, how do you categorize the patient into STEMI or NSTEMI? The ST segment elevation is considered suggestive of an ongoing coronary artery acute occlusion if there is elevation in at least 2 contiguous leads. The elevation should be greater than or equal to 2.5 millimeters in men less than 40 years, or greater than or equal to 2 mm in men more than 40 years. In more than 1.5 millimeters in women, regardless of age in leads V2 to V3, and or more than 1 mm in the other leads in the absence of LV hypertrophy or fund branch block. In case of NSTEMI, there is a wide variety of ECG changes. There can be transient ST segment elevation or persistent or transient ST segment depression. There can be T wave abnormalities, hyperacute T waves, T wave inversion, biphasic T waves, flat T waves, and pseudonormalization of T waves. So these recommendations are from the ESC guidelines, which were updated in 2023 and published in the European Heart Journal. A 12-lead ECG recording and interpretation is recommended within 10 minutes of the first medical contact of the patient. And continuous ECG monitoring and availability of defibrillator is necessary. And the use of additional ECG leads, such as V3, V4, V5 to V7 to V9 is recommended in case of inferior STEMI, or if any total vessel occlusion is suspected. Moving on to biomarkers. The measurement of a biomarker of cardiomyocyte injury, preferably a high sensitivity cardiac troponin, is recommended in all patients with suspected ACS. And these results have to come in within 60 minutes of the blood sampling. And it is also recommended to use the European Society of Cardiology algorithmic approach, that is, with serial high sensitivity troponin measurements at the time of arrival and at 1 hour or 2 hours later, in order to rule in or rule out the NSTEMI. This rule in, rule out of NSTEMI with serial TROP-T measurements have shown good validity, especially with a negative predictive value in trials conducted such as a rapid TNT trial, which was published in Circulation Journal in 2019, a rapid CPU trial, which was published in European Heart Journal in 2019. An additional testing after 3 hours is recommended in case these initial 0 hour and 1 hour or 0 hour and 2 hour measurements were inconclusive and no alternate diagnosis was found. So this is the algorithm approach. If a patient presents with a suspected NSTEMI and without an indication for an immediate invasive angiography, then we have to take high sensitivity cardiac troponin levels soon after arrival and after 1 hour or after 2 hours. So in case the patient had a very low initial troponin levels and there was no further increase at 1 hour or 2 hours, they go into the rule out pathway. And this has a negative predictive value of 99%, and the patient can be either safely discharged or be managed on an OPD basis. If there was a high initial cardiac troponin level and there was a persistent increase at 1 hour later or 2 hours later, then they go into the rule in pathway. This has a positive predictive value of 70 to 75%, and these patients, they will have to be admitted and considered for a coronary angiography. In case the patients do not meet either of these criteria, we can always repeat the value at 3 hours later along with an echocardiography. And if there is a high suspicion based on clinical findings, then the patient has to go in for a coronary angiography, or they can be kept in the observed pathway. Moving on to non-invasive imaging, with respect to transthoracic echo, the recommendations are emergency TT is recommended in patients who are presenting suspected ACS presenting with cardiogenic shock or any mechanical complication. It should be considered a triage, but this should not result in delays in transfer to the cath lab. With respect to CT coronary, routine early CCTA is not recommended. As evidenced by these 3 trials as a Beacon trial, Romicat, and rapid CTCA trial, there was no reduction in the hospital stay or no improvement in clinical outcomes by doing a routine early CCTA. But in patients with ACS, but they don't have elevated troponin levels, they don't have any ECG changes, and there is no recurrence of pain, then incorporating CCTA or a non-invasive stress imaging as a part of the initial workup should be considered. So the cardiac troponin levels, when they're getting elevated, they only indicate myocardial injury and not necessarily myocardial ischemia. There are so many other conditions where the troponin levels can get elevated. So injury can be either because of a thrombus or because of any oxygen supply demand imbalance. And other systemic conditions where one can get confused with increased troponin levels are sepsis, CKD, stroke, subarachnoid hemorrhage, pulmonary embolism, when the patient is using any chemotherapeutic agents, and basically in any critically ill patient. These are other conditions where troponin levels can get elevated. So based on this, there's a general algorithm. If you're having a patient with raised troponin levels, in case it is more than 99 percentile, the upper reference limit, is there an acute rise or fall in the troponin on the serial measurements? If it is there, is it associated with findings suggestive of an acute ischemia? If it is so, then it is suggestive of acute myocardial infarction, which can be either due to a thrombus or because of the imbalance as type 1 MI or type 2 MI. In case it is not associated with findings suggestive of acute ischemia, then it is just acute myocardial injury. This injury can be because of any heart failure or myocarditis due to any cause. In case the troponin levels are stable, there is no acute rise or fall, then it is chronic myocardial injury, which can be because of any structural heart disease or chronic kidney disease. So next, moving on to the initial measures for patients who are presenting with acute coronary syndrome. The pre-hospital logistics of care is very important. because the patient may either present directly to a clinician or to a nursing home or to a small clinic, or they may call it EMS. So wherever they present to, that place should have an access to ECG with the ability to risk stratify into a STEMI or an NSTEMI, and they should be able to shift to a hospital with 24/7 PCI facility as soon as possible. And efforts must be taken at every step to avoid delays, to shorten the total ischemic time, and to select the perfect reperfusion strategy. Basically, time is hard. Suppose you have a patient presenting with symptoms of ACS. They have self-presented themselves to the hospital, or they must have called an EMS. And in both places, ECG has been done, which is showing STEMI. So the hospital where they have initially presented to, that is the first medical contact. Is that hospital PCI equipped? If it is so, then the time to wire crossing should be less than 60 minutes. If it is not PCI equipped, will they be able to transport or will they be able to make sure that the patient undergoes a PCI within 120 minutes? If that is so, the door in and door out time should be less than 30 minutes to a PCI center, and the AM is less than 90 minutes to wire crossing. If PCI is not possible within 120 minutes, then less than 10 minutes to a lytic bolus of a thrombolytic agent is required, and immediate transfer to a PCI facility is recommended. In case the patient calls the EMS, the patient is in an ambulance, and in the ambulance, the ECG is showing STEMI. Here also, we have to determine whether the PCI is possible within 120 minutes. Then the target is less than 90 minutes to wire crossing. If PCI is not possible within 120 minutes, then less than 10 minutes to a lytic bolus and immediate transfer to a PCI facility is recommended. So one can always bypass the emergency department of the PCI facility enabled hospital directly to the cath lab if the EMS recognizes STEMI and sends the patient for PCI. If there is no facility, as I said, door in and door out time must be less than 30 minutes, and the ambulance in which the patient is traveling must be well equipped and capable of administering fibrinolysis, pain relief, and basic life support. So acute phase management of ACS with respect to invasive strategy for STEMI, the recommendations published were the reperfusion strategy is recommended in all patients of STEMI with symptoms of ischemia of less than 12 hours duration. Primary PCI strategy is recommended over fibrinolysis if the anticipated time from diagnosis to PCI is less than 120. If timely PCI cannot be performed, then fibrinolytic therapy is recommended within 12 hours of symptom onset in patients without contraindications. With respect to acute pharmacotherapy, what are the medications that you can give immediately? If the patient is having hypoxia, oxygen is recommended. If the saturation is less than 90, if it is more than 90, routine oxygen is not recommended. In case of pain relief, intravenous opioids should be considered. And beta blockers, preferably metoprolol, should be considered at the time of presentation in patients undergoing primary PCI with no signs of acute heart failure or with a systolic blood pressure of more than 120. Intravenous nitrates are useful in the acute phase of MI provided there is no RV dysfunction or no hypertension. In the ICES-4 trial, it was proven that oral nitrates had no survival benefit in MI patients, and the use is restricted only to the control of residual angina and in chronic coronary syndrome. The time interval between fibrinolysis and PCI should be within 110 minutes. And rescue PCI is recommended if there is failure of fibrinolysis. That is, if the ST segment resolution is less than 50% within 60 to 90 minutes of fibrinolytic therapy. If there is hemodynamic instability, if there is persistent chest pain, electrical instability, or worsening ischemia. But even if the fibrinolysis is successful, CAG and PCI, if it is indicated, it is recommended within 2 to 24 hours of the fibrinolytic therapy. In case the anatomy is not suitable for PCI, you take the patient to cath lab and the anatomy is not suitable for PCI, immediately the OT has to be prepped for an emergency CABG. Invasive strategy in ST elevation MI who are late presenters. Routine PCI is not recommended in stable patients with no persistent symptoms when they present more than 48 hours after the symptom onset. This has been proven by the occluded artery trial, where late recanalization of the infarct-related artery showed no benefit of reperfusion. So conservative management was recommended. In case of stable patients presenting late, that is within 12 to 48 hours after symptom onset, they should be considered for routine PCI as per the FAST MI trial. And in case of patients who are presenting with ongoing symptoms of ischemia, hemodynamic instability, or life-threatening arrhythmias more than 12 hours, definitely a primary PCI is recommended. Invasive strategy for non-ST elevation MI. In case a patient presents with symptoms of ACS and the ECG is consistent with non-ST elevation features, the patients are classified into very high risk and non-high risk patients. The very high risk patients are those who are presenting with hemodynamic instability or in shock, those who are having recurrent or ongoing chest pain refractory to medical treatment, those who are having heart failure secondary to ischemia, life-threatening arrhythmias, any mechanical complications, or recurrent dynamic ECG changes suggestive of ischemia. If these patients are initially in a non-PCI center or on the ambulance, they should be immediately transferred to a PCI center, and immediate invasive strategy is recommended in these patients if they belong to the high-risk category. In case of high-risk category, you're talking about patients with a confirmed diagnosis of NSTEMI based on ESC algorithms, transient ST segment elevation, or dynamic ST segment or T-wave changes. So these patients should also be immediately transferred to a PCI center. Inpatient invasive strategy is recommended, but early, that is within 24 hours, invasive strategy should be considered in these patients. In case of non-high-risk patients, they can be transferred to a PCI center, and selective invasive strategy is recommended in these patients. So the various fibrinolytic agents that are in use are streptokinase, altiplase, retiplase, and tenecteplase. Although altiplase and tenecteplase are more commonly used. Altiplase is given as a 15 mg IV bolus, that is 0.75 mg per kg over 30 minutes, and then 0.5 mg per kg over 60 minutes. And tenecteplase is based on weight-based dosing. That is 30 mg, patients are less than 60 kgs, and for every 10 kgs, there is 5 mg increase. So there are various contraindications to thrombolytic therapy, though. There are absolute and relative contraindications where the patient had any prior ICH or ischemic stroke, dissection, recent surgery, head trauma. These are all absolute contraindications. Relative contraindications are patients who are more than 75 years of age, uncontrolled hypertension, pregnancy, those who are on current oral anticoagulation. So these patients are having relative contraindication. So with respect to the fibrinolytic therapy, the recommendations are, so when fibrinolysis is a reperfusion strategy of choice, it has to be within 10 minutes of diagnosis in the ECG. A fibrin-specific agent such as tenecteplase, altiplase, or retiplase is recommended, and a half dose of tenecteplase should be considered in patients above 75 years of age. Moving on to antithrombotic therapy. Antithrombotic therapy includes antiplatelets and anticoagulation drugs. So aspirin is a cyclooxygenase inhibitor, which inhibits the formation of thromboxane. So initial loading dose is 150 to 300 milligrams orally, followed by a maintenance dose of 75 to 100 milligrams orally. There are P2Y12 receptor inhibitors such as clopidogrel, prasugrel, ticagrelol, and cangrelol. So clopidogrel is given in a loading dose of 300 to 600 orally, followed by a maintenance of 75 mg. Prasugrel is initial loading dose of 60 mg, followed by a maintenance of 10 mg in patients who are weighing less than 60 kg. And in case of patients aged above 75 years, the prasugrel dose is reduced to 5 mg. Prior stroke is a contraindication for prasugrel. Ticagrelol is given as a loading dose of 180 mg initially, followed by maintenance of 90 mg BD. Cangrelol is an IV antiplatelet where a bolus of 30 mics per kg is followed by 4 mics per kg per minute for at least 2 hours or for a duration of the procedure, whichever is longer. And other antiplatelets, IV antiplatelets are GP2B3A inhibitors, receptor inhibitors such as eftifibatide and tirofiban. Eftifibatide is given as a double bolus of 180 mics per kg at 10-minute intervals, and it is followed by a 2 mics per kg per minute infusion for up to 18 hours. And tirofiban is given as 25 mics per kg over 3 minutes, followed by 0.15 milligram per kg up to 18 hours. Both of these are not recommended. They are contraindicated in case of end-stage renal disease, in case of prior ICH, ischemic stroke within 30 days, patients who have underwent fibrinolysis, or if the platelet count is less than 1 lakh. Among anticoagulation, unfractionated heparin is what we use most commonly. The IV bolus are 70 to 100 units per kg, followed by IV infusion. And the enoxaparin is another alternative. And if during PCI, in case of patients who have already been receiving enoxaparin, if the last dose was given less than 8 hours before balloon inflation, there is no need for additional dosing. If the last dose was given more than 8 hours, then IV bolus of 0.3 milligram per kg is recommended. In case of bivalirudin, the dose is 0.75 milligram per kg, followed by IV infusion of 1.75 milligram per kg per hour. And this is the only anticoagulation drug which is continued for 4 hours after the procedure. So the choice of antiplatelet should take the bleeding risk of the patient into account. The ARC, that is Academic Research Consortium, made a ARC HBR criteria, that's major and minor HBR criteria. And according to their definition, patients are considered to be at high bleeding risk if at least one major and two minor criteria are met. So these are all the major criteria, and this is the minor criteria. Any patient with liver cirrhosis, portal hypertension, hemoglobin less than 11, with CKD, and baseline thrombocytopenia of less than 1 lakh, they all come under major high bleeding risk criteria. Minor criteria are patients who are above 75 years, they have moderate CKD, hemoglobin is between 11 to 12.9, and long-term use of oral NSAIDs or steroids. So based on this, the choice of antiplatelet should be made. So the Plateau trial and the Triton TMI 38 studies were done. As per these studies, a DAPT therapy including aspirin and a potent P2Y12 inhibitor, a receptor inhibitor, is recommended for all ACS patients. And so the most recommended P2Y12 inhibitor, receptor inhibitor, is prasugrel or ticagrelol. And prasugrel is recommended in the patients who are proceeding to PCI. And ticagrelol is recommended irrespective of a treatment strategy. Clopidogrel is recommended only when prasugrelol or ticagrelol are not available, they cannot be tolerated, or if they are contraindicated, and in patients aged above 75 years. So this was the ISA REACT 5 trial, which compared ticagrelol or prasugrel in patients with ACS going in for PCI. And in them, prasugrel was shown to be superior to ticagrelol in terms of the incidence of death or myocardial, reducing the incidence of death, myocardial infarction, or stroke. Moving on to intravenous antiplatelets, like I had explained earlier, it is eptifibatide and tirofiban. There is no strong evidence for any additional benefit of usage of these IV antiplatelets. They should be considered only if there is evidence of no reflow or a thrombotic complication during PCI, or in case of high-risk PCI in patients who have not been pre-treated with P2Y12 receptor inhibitors earlier. Cangrelor is yet another IV antiplatelet which we saw earlier. As per these trials, it's a Champion PCI platform and Champion Phoenix trials. The benefit of cangrelor with respect to major ischemic endpoints was counterbalanced by an increase in the minor bleeding complications. So it can only be considered on a case-by-case basis. So in case of P2Y12 receptor inhibitor naive patients, that is those who have not received these drugs earlier, cangrelor may be considered. Otherwise, it is only on a case-by-case basis. Moving on to whether pre-treatment with antiplatelets, it is necessary in patients with suspected ST elevation MI. The Atlantic trial was the only randomized study which tested the safety and efficacy of different timings of the P2Y12 receptor inhibitor initiation. So the conclusion from that study was the pre-treatment strategy failed to meet the pre-specified primary endpoint. That is, there was no improved ST segment elevation resolution, neither there was increase in the TIMI flow. That is before the intervention. And when it comes to non-ST elevation acute coronary syndrome, the ACOS trial proved that pre-treatment with prasugrel in NSTEMI patients did not reduce the major cardiovascular risk. In fact, it increased the bleeding risk. So pre-treatment with a P2Y12 receptor inhibitor may be considered in a patient who is undergoing a primary PCI. And it may be considered in non-ST elevation patients who are not expected to undergo an immediate or an early invasive strategy, and in patients who don't have a high bleeding risk. Pre-treatment with a GP2B3 receptor antagonist is not recommended at all. And routine pre-treatment in a patient who is already scheduled for an immediate angiography is not recommended. So this is a default antiplatelet therapy which we see in patients presenting with ACS. So in case of STEMI, pre-treatment with aspirin is recommended, and with a P2Y12 inhibitor may be considered. In case of NSTEMI though, it is not recommended. And in case of choice of P2Y12 inhibitors, prasugrel and ticagrelol are the inhibitors, antiplatelets of choice. And only if they are not available or contraindicated, clopidogrel is recommended. And in case of patients proceeding to PCI, prasugrel is preferred over ticagrelol, and it should be considered. And default DAPT strategy for the first 12 months is usually aspirin with a P2Y12 inhibitor, and beyond 12 months is usually aspirin. There are different modifications to this dual antiplatelet therapy with the sole aim of reducing the bleeding risk. One is shortening the dual antiplatelet therapy. The other one is the de-escalation of a P2Y12 inhibitor, potent one to clopidogrel. So with respect to shortening of the dual antiplatelet therapy, several RCTs and meta-analysis have been done, where you compare a standard 12-month DAPT with a 6-month DAPT followed by aspirin monotherapy. The reduction in the bleeding events, however, it came at a cost of an increase in the rate of ischemic complications. And then there was the TICO study and the Twilight study, which compared the ticagrelol monotherapy versus ticagrelol plus aspirin for 1 year after 3 months of DAPT. Here, the bleeding events were significantly reduced by omitting aspirin after 3 months. And the findings were somehow consistent with almost 4,000 patients with NSTEMI also. And the STOP DAPT to ACS trial is where clopidogrel monotherapy was started after 2 months of DAPT and versus continued DAPT for 12 months. When it comes to de-escalation from a potent P2Y12 inhibitor to clopidogrel, again here the main aim is to reduce the number of bleeding events, but this has a potential risk of increased ischemic events. So this de-escalation should not be attempted within the first 30 days after an index ACS event. So there was a tropical ACS study where DAPT de-escalation from prasugrel to clopidogrel was actually done within 2 weeks after ACS. But that was found to be non-inferior to standard treatment with prasugrel at 1 year after PCI. And there was a topic study where after 1 month of DAPT, it was changed to prasugrel was changed to clopidogrel. And here no adverse clinical events and bleeding events were seen, whereas the rate of ischemic endpoints were unchanged. And then there was a Talos AMI trial, again after 1 month of ticagrelol, clopidogrel was changed, where significant 1 to 2 months reductions in net adverse clinical events and bleeding events were seen. So the recommendations with respect to this is, in case the patients are event free after 3 to 6 months of DAPT and they do not have a high ischemic risk, a single antiplatelet therapy, preferably a P2Y12 inhibitor, should be considered. And the de-escalation of a P2Y12 inhibitor may be considered as an alternative DAPT strategy in order to reduce the bleeding risk. In case of high bleeding risk patients, aspirin or P2Y12 receptor inhibitor monotherapy after even 1 month of DAPT may be considered. And the de-escalation of antiplatelet therapy in the first 30 days is never recommended. Moving on to anticoagulation in the acute phase. So in case of patients with STEMI who are undergoing PPCI, the most commonly used anticoagulation drug is unfractionated heparin. In the ATOL study, enoxaparin was compared with unfractionated heparin, and a reduction in the primary endpoint at 30 days was noted. And BRIGHT 4 is where bivalirudin was compared with heparin. 6,000 patients with STEMI undergoing PPCI were randomized to either bivalirudin or heparin, and the risk of stent thrombosis was reduced in the bivalirudin group. So as I mentioned earlier, bivalirudin is the only anticoagulation drug where a full dose post-PCI infusion should be considered. And there was a OASIS 6 study where fondaparinux was studied. And it was recommended that fondaparinux should not be used in patients with STEMI undergoing PPCI. So this is what I had just mentioned earlier. Only thing is enoxaparin as an alternative to heparin should be considered in these patients. In case of patients with NSTEMI who are undergoing angiography and PCI if indicated. If you're planning an immediate or an early angiography, inflationary heparin is most commonly given, but enoxaparin or low molecular weight heparin should be considered. And in case of angiography, which is planned beyond 24 hours, as per the OASIS 5 trial, fondaparinux therapy is recommended in preference to enoxaparin. But because of a guiding catheter thrombus formation, a full dose bolus of unfractionated heparin should be given if the patient proceeds to PCI. And the intravenous heparin should be considered as an anticoagulation for PCI in patients with non-ST elevation, in whom subcutaneous enoxaparin was used while awaiting coronary angiography. So this is the anticoagulation strategy in patients with NSTEMI and STEMI. In case of STEMI, enoxaparin should be considered over unfractionated, even though unfractionated heparin is recommended. Fondaparinux is not recommended. And in case of non-ST elevation, if it is within 24 hours, it's either enoxaparin or unfractionated. And more than 24 hours, fondaparinux is recommended. Antiplatelet therapy in patients who require oral anticoagulation. In almost 6 to 8% of patients who undergo PCI, a long-term oral anticoagulation is indicated. And this interruption of a long-term oral anticoagulation bridging with a parenteral anticoagulant may lead to increase in certain thromboembolic episodes and bleeding. In case of vitamin K antagonist treated patients, no parenteral anticoagulation is necessary if the INR is more than 2.5. And the indication for oral anticoagulation should be reassessed. And they should be continued only if there is a compelling indication in the form of AF, in the form of mechanical heart valve or recurrent unprovoked DVT. And use of prasugrel or ticagrelol is not a part of this triple antithrombotic therapy, which I'll be explaining earlier. The intensity should always be monitored in order to maintain an INR of 2 to 2.5. So these recommendations mention the same which I just said, except that here there's additional regarding rivaroxaban and dabigatran. In case of patients with bleeding risk, rivaroxaban 15 mg should be considered in preference to rivaroxaban 20 mg. And dabigatran of 110 mg BD should be considered in preference to dabigatran 150 mg BD in case of patients with high bleeding risk. So, in patients who require oral anticoagulation and treated medically, a single antiplatelet agent along with the oral anticoagulation, that is dual antithrombotic therapy, should be considered for a period up to 1 year. In case of patients treated with OAC, aspirin with plus clopidogrel for longer than 1 week and up to 1 month should be considered in patients who are having a high ischemic risk. That is a triple antithrombotic therapy. That is a DAPT with the oral anticoagulation should be considered for 1 week to up to 1 month in case of patients with high ischemic risk. And in case of patients requiring oral anticoagulation, you can withdraw antiplatelet therapy at 6 months while continuing the oral anticoagulation therapy for the next 6 months. That is up to 1 year and beyond that also. This may be considered in certain patients. However, the use of ticagrelol or prasugrel is not a part of this therapy. And discontinuation of antiplatelet therapy is recommended in patients who are treated with oral anticoagulation beyond the period of 12 months. So after 12 months, if the patient requires an oral anticoagulation for other reasons, we have to stop the antiplatelet therapy. So there are various strategies to reduce the bleeding risk, such as the anticoagulation dose should be adjusted to body weight and renal function. Proton pump inhibitors must be used because of the high potential to cause gastric ulcers which can bleed. And in case of patients on oral anticoagulation, PCI must be performed without interruption of the vitamin K antagonist or NOACs. And you should not administer unfractionated heparin to INRs more than 1.5. And regardless of the timing of the last administration of NOAC, add a low dose parenteral anticoagulation, preferably enoxaparin at 0.5 milligram per kg. And GP2B3A inhibitors are not recommended except for bailout or peri-procedural complications. Antithrombotic therapy with fibrinolytic therapy, the combination, the benefits of aspirin and fibrinolytics were additive in the ISIS-2 trial. And clopidogrel added to aspirin did reduce the risk of cardiovascular events. So the most commonly studied and most extensively used pharmacoinvasive strategy is a weight-adjusted dose of IV tenecteplase with a low-dose aspirin clopidogrel given orally, and enoxaparin IV followed by subcutaneous administration until the time of PCI. So this is the most commonly studied and used anti-thrombotic with fibrinolytic regimen. So anticoagulation is recommended in patients treated with fibrinolysis until revascularization or for a duration of hospital stay up to 8 days. So enoxaparin IV followed by subcutaneous is recommended. If it is not available, unfractionated is recommended. Moving on to lipid lowering therapy in ACS. In case of the patient presenting with ACS, if they have not been treated before with lipid lowering therapies, they are known as LLT naive patients. And such patients have to be initiated on a high potency or high dose statins. And a combination therapy with statin and ezetimibe should be considered. In case they were on a low potency or low dose statins, then they have to be upgraded to high potency, high dose statins, and a combination therapy with statin and ezetimibe should be considered. In case they were already on highest tolerated statin dose, then you have to check the LDL levels. If the LDL levels are less than 55, then there is no need for any change in therapy. In case they are more than 55 milligram per deciliter, then you have to add an ezetimibe. If they are on the highest tolerated dose of statins and ezetimibe, then if the LDL is less than 55 milligram per deciliter, there is no need for change in therapy. In case it is more than 55 milligram per deciliter, then we have to consider a PCSK9 drug, which is a pro-protein convertase subtylsin kexin inhibitor type 9 drug, which internalizes the LDL receptors into the lysosomes. And in case the patient was already on an lipid lowering therapy and they have presented with an ACS within 2 years, and they are already taking the maximum tolerated statin-based therapy, then the LDL goal should be less than 40 milligram per deciliter. And in ACS in patients with unstable presentation, first among this is out-of-hospital cardiac arrest. In this scenario, always the concern is whether the patient should be taken up for an immediate angiography post-ROSC or not. Multiple trials were conducted on this basis, such as COVAC, Tomahawk, Emerge, Pearl, and COOP trials. And the final recommendation is that a PPCA strategy is recommended in resuscitated cardiac arrest patients with persistent ST segment elevation. But it is not recommended in hemodynamically stable without persistent ST segment elevation. And the rest of the aspects of post-ROSC care is the same as any cardiac arrest algorithm. In case a patient presents in cardiogenic shock, which is complicating acute coronary syndrome, what should be done? So there was a shock trial which recommended early revascularization with either PCI or CABG in patients with in AMI complicated by cardiogenic shock. There was IABP shock 2 trial where the IABP use was not associated with a lower 30-day mortality. Therefore, in the absence of mechanical complications, the routine use of IABP is not recommended in cardiogenic shock. So in patients with ACS and severe refractory cardiogenic shock, short-term mechanical circulatory support devices may be considered, although the routine use of IABP is not recommended. So a brief account of all the mechanical circulatory devices that we know are mostly this IABP, impeller, tandem heart, and VA ECMO. IABP tends to provide a cardiac flow of 0.3 to 0.5 liters per minute, impeller 1 to 5 liters, tandem heart 2.5 to 5 liters per minute, and ECMO 3 to 7 liters per minute. So all these are the mechanical circulatory devices which can be used for a short period as a bridging mechanism. Going on to the technical aspects of the invasive strategies briefly, with respect to vascular access, radial access is always recommended. And with respect to intravascular imaging, if on coronary angiography, you are able to see a clear culprit lesion, intravascular imaging can be used to guide the PCI, and PCI is being done. In case there is no clear culprit lesion visible on routine coronary angiography, then also use intravascular imaging, such as IVUS or an optical coherence tomography. And you identify what kind of lesion it is, whether it is erosion, nodule rupture, SCAD, or there is no lesion at all, and treat as per the image findings. With respect to balloons and stents, PCI with stent deployment in the infarct-related artery during the index procedure itself is recommended, and drug-eluting stents are always recommended over bare metal stents. Spontaneous coronary dissection. Patients with spontaneous coronary dissection, PCI is recommended only for patients with symptoms and signs of ongoing myocardial ischemia, large area of myocardium in jeopardy, and reduced antigrade flow. And management of patients with multivessel disease. So cardiogenic shock can usually present with a multivessel involvement, and it can occur in up to 4 to 11 patients of 11% of ACS patients. Nearly 80% of ACS patients, they have with cardiogenic shock, they have multi-vessel involvement. The culprit shock trial recommended that a PCI during the index procedure should be restricted to the infarct-related artery only, and a significant reduction in all-cause death or renal replacement therapy at 30-day follow-up was noticed with this particular strategy. In case of patients with multivessel coronary artery disease who are undergoing primary percutaneous coronary intervention, there were numerous studies in support of doing a preventive revascularization of the non-infarct related artery also. So when you come to this algorithm, in case a patient is presenting with cardiogenic shock, he is unstable, he is hemodynamically unstable. So in such a patient, the immediate PCI of the IRA only is recommended, and a staged complete revascularization should be considered. In case a patient is presenting with STEMI, complete revascularization is recommended. Either you do it during the index procedure or you do it within 45 days. In case of patients with non-ST elevation, complete revascularization should be considered. If there is any doubt, then functional invasive evaluation of the non-infarct related artery during the index procedure should be considered. What is MINOCA? MINOCA is myocardial infarction with non-obstructive coronary arteries. These patients, they tend to present with symptoms suggestive of ACS. The troponin is elevated, but on angiography, the coronary artery stenosis is less than 50% in any major epicardial vessel. The incidence is between 1 to 14%, and the various causes can be there for MINOCA to occur, such as coronary causes, non-coronary, but cardiac causes and non-cardiac causes. So coronary causes can be coronary embolism, spasm, myocardial bridging, and SCAD, that is spontaneous coronary artery dissection. Non-coronary but cardiac causes could be any myocarditis or cardiomyopathies. Non-cardiac causes could be ARDS, end-stage renal disease, any inflammation, sepsis, stroke. So further investigation must be done to find out the underlying cause for this MINOCA, and steps must be taken to address these issues as soon as possible. So CMR, that is cardiac MRI, can identify the underlying cause in up to 87% of the patients with a working diagnosis of MINOCA. The management of the complications of ACS. Heart failure is one of the major complications, and always there can be a confusion, that is between a de novo acute heart failure complicating ACS and pre-existing heart failure exacerbated by ACS. So even the increased troponin levels can be confusing in patients with acute heart failure, can also have increased troponin levels because of the myocardial injury rather than due to the ischemia itself. However, in patients presenting with acute heart failure complicating ACS, immediate ICA is recommended, and IABP should be used as an adjunct in these patients when they are hemodynamically unstable. So just a short note regarding IABP, intra-aortic balloon pump is a mechanical circulatory device. It is inserted and used in patients in cardiogenic shock, those undergoing revascularization, or as a bridge to intervention of an interfacility transport. So there is a balloon which is passed, and the tip of the balloon is placed around 1 to 2 centimeters beyond distal to the left subclavian artery. And this balloon is deflated during systole and inflated during diastole. So the deflation during systole helps in reducing the afterload and increasing the cardiac output. And the inflation of this balloon during diastole helps in increasing the diastolic blood pressure and increasing the coronary perfusion. So basically, they have two triggers, ECG and pressure trigger. And so overall, they help in reducing the afterload, increasing the cardiac output, increasing the coronary perfusion. So various complications can also occur because of IABP, such as limb ischemia, bleeding, hematoma, decreased augmentation, because there are minimal cardiac index of more than 1 is required to augment, and worsening cardiac ischemia can also occur as a complication. LV thrombus is yet another complication of ACS, which occurs in 9% of patients with anterior STEMI. Cardiac MRI is the only gold standard method of diagnosing, and once it has been diagnosed, then the patient has to be kept on an oral anticoagulation therapy for at least 3 to 6 months, and following which continuation of the therapy should be guided by repeated echocardiography or a cardiac MRI. Arrhythmias. These are very important complications of ACS. Various arrhythmias can be seen. One is atrial fibrillation. So intravenous beta blockers are recommended in the absence of acute heart failure or hypertension. Amiodarone is recommended in the presence of heart failure, but there should not be any hypertension. In case of patients with hemodynamic instability, immediate electrical cardioversion is recommended. And amiodarone has to be continued after electrical cardioversion in order to prevent recurrence. And these patients have to be kept on long-term oral anticoagulations also. In case of ventricular arrhythmias, ICD therapy is recommended to reduce sudden cardiac death. And it is mainly recommended in patients with an ejection fraction of less than 35%, in spite of an optimal medical therapy for more than 3 months or at least 6 weeks after MI, and only if they are expected to survive for more than a year with a good functional status. And prompt and complete revascularization is recommended to treat the ischemia. Transvenous catheter pacing is recommended if it cannot be controlled by electrical cardioversion. RF ablation is recommended should be considered in case of recurrent VT, VF or electrical storm, despite the complete revascularization that we have done and optical medical therapy. Lidocaine can be considered in conditions of beta blocker or amiodarone does not work. And sedation is also might be necessary in order to reduce the sympathetic drive in these patients. And an ICD implantation or a cardioverter defibrillator is recommended may be considered in less than 40 days after MI. In case of incomplete revascularization, any pre-existing LVEF dysfunction, recurrence of arrhythmias for more than 48 hours after the STEMI onset, or in case of any polymorphic VT. In case of bradyarrhythmias, sinus bradyarrhythmia with hemodynamic intolerance or high degree AV block, a positive chronotropic medication must be started, temporary pacing must be done, urgent angiography has to be done, and a permanent pacemaker is recommended when the high degree AV block does not resolve within a waiting period of at least 5 days after MI. And in selected patients, patients have to go in for a CRTD or a CRTP. And pacing is not recommended if the high degree AV block resolves after revascularization or spontaneously. So the indications for ICD and CRT is different. ICD is, as told, it is recommended in patients with documented VF or hemodynamically not tolerated VT, absence of reversible causes or within 48 hours after MI, and reasonable expectation of survival with a good functional status of more than 1 year and severely impaired LV function. And despite optimal medical therapy for more than 3 months, ischemic cardiomyopathy and non-ischemic cardiomyopathy. CRT is recommended in patients with ejection fraction less than 35 with an LBV of more than 150 milliseconds. So just a brief recommendation, brief 2 slides regarding recommendations in patients with comorbidities, only covering CKD and cancer in this. So the use of low or isoosmolar contrast media is necessary in CKD patients in order to, because these patients are at high risk of contrast-induced nephropathy, and it is recommended to assess kidney function using EGFR in all patients. And hydration during and after angiography should be considered in these patients at risk of contrast-induced nephropathy. In case of patients with cancer, the invasive strategy is recommended only if the expected survival is more than 6 months. And in case of patients with a high bleeding risk or expected survival of less than 6 months, conservative non-invasive strategy should be considered. Aspirin is not recommended if the platelet count is less than 10,000. Clopidogrel is not recommended if the counts are less than 30,000. And prasugrel or ticagrelol is not recommended if the counts are less than 50,000. Last, going on to the long-term treatment after ACS, patients are usually discharged on cardioprotective medications, and the treatment goals are usually to support a healthy lifestyle choices, smoking cessation, healthy diet, regular exercise, and adherence to pharmacological therapy, such as antithrombotic therapy, lipid-lowering therapy, etc. And also sustain risk factor treatment targets. You have to maintain blood pressure of less than 130 by 80, maintain the LDL levels less than 55, maintain HbA1c less than 7%. So finally, the take-home message is ACS encompasses a spectrum of clinical presentation and ECG findings, and the diagnosis can range from unstable angina to ST elevation MI. So always you should think ACS at the initial assessment, that is abnormal ECG, clinical context, what kind of chest pain it is, and hemodynamics and vitals of the patient, whether the patient is stable or not. And once you look at the ECG, you have to think about the invasive management. If it is STEMI, can the patient go in for a PCI immediately? If yes, patient, the wire crossing time should be within 120 minutes, a patient has to undergo PCI after fibrinolysis. If no, the patient cannot undergo a PCI within 120 minutes, and fibrinolysis has to be given within 10 minutes of the ECG diagnosis. In case of very high risk non-ST elevation, immediate angiography is preferred. In case of high risk, early, that is within 24 hours angiography should be considered. And you have to think about the anti-thrombotic therapy, antiplatelets and anticoagulation therapy. Aspirin with a P2Y12 inhibitor is most commonly recommended up to 1 year. Among the P2Y12 inhibitors, prasugrel and ticagrelol is most recommended. Clopidogrel is only when either of these two are contraindicated or they are not available, and in patients above 75 years of age. Beyond 1 year, P2Y12 is recommended. And in case of anticoagulation therapy, with respect to STEMI, it is unfractionated heparin is most commonly used, but LMWH should be considered in these patients if their renal status is normal. And vivalirudin is yet another alternative, and it's one of the only anticoagulation therapy which is continued even after the PCI is done. And fondaparinux is not recommended in STEMI, but it's recommended in STEMI patients who are planned for a delayed PCI strategy, not in the ones who are planned for PCI immediately. And in case of revascularization, the options between a PCI and an emergency CABG. CABG takes a lot of time to prepare, so it is only considered in case of where the anatomy is not suitable for PCI. And the aim for complete revascularization has to be there in case of multi-vessel PCI. But if the patient is hemodynamically stable, as in a case of cardiogenic shock, you always do the PCI for the infarct-related artery first, and a staged PCI should be considered later. In case of STEMI, complete revascularization has to be completed within 45 days. And in case of NSTEMI, complete revascularization during the index procedure should be considered. And if it is difficult to find out the lesion in a routine coronary angiography, intravascular imaging can be used to help to find out the lesion. And finally, you have to think about secondary prevention in terms of adherence to anti-thrombotic therapy, lipid lowering therapy, lifestyle changes such as smoking cessation, cardiac rehabilitation, and risk factor management, as well as psychosocial considerations. Thank you.
Kansham?
Thank you, Ranjana. I think it was a very, very extensive review of acute coronary syndrome evidence-based management. I think as intensivists, we see patients from wide variable conditions. Patients may come with stable MI and then maybe get a stent and come to the ICU, or patients may come in cardiogenic shock, cardiac arrest scenario, rush to the cath lab, and then brought post coronary intervention. Sometimes we may have patients who may be in the ICU for a different reason, but may develop a myocardial ischemia or an acute coronary while in the ICU, and maybe may need rushing to the cath lab for a revascularization strategy. And many times we come across situations where there is always a question of should we take the patient to a cath or not when there are doubtful situations. I think the key aspects or the areas where as intensivists we will be very closely involved in the management of patients with acute coronary syndrome would be patients who come with acute coronary syndrome and land up in a cardiogenic shock scenario. I think there's a increasing role of mechanical circulatory support after you have given the initial pharmacotherapeutic support. And then a good number of these patients can end up with renal injury, both because of the cardiac shock itself per se, as well as the contrast that is usually given during the percutaneous interventions. So that is something that we need to be very, very carefully watching. And a good number of these patients may keep going into repeated pulmonary edemas. You may achieve the revascularization, but we still find a good number of these patients may have a residual LV dysfunction and keep going into pulmonary edema, and weaning might be a difficult thing in such situations. Uh, we talk about fluid balance very liberally in patients with septic shock, but even cardiac shock patients might need some amount of fluid. It's not that just because they have cardiac shock with LV dysfunction that they don't need. We just need to be more meticulous, probably less aggressive, but still keep a watch on the fluid balance. Extremely important to maintain your electrolytes because an irritable myocardium is prone for arrhythmias, especially after a coronary intervention. And lastly, though there is a strong recommendation for not using routine proton pump inhibitors, I think this is one subset of patients where I would normally prescribe a PPI because we have seen a good number of these patients having GI bleeds very very often. So just keep those things in mind. That's it, Srinivas, from my side.
I think the average age of MI and cardiogenic shock in India has fallen by a good 7 to 8 years in the last 10 years. So from the high 40s, it has come down to the high 30s. As per the last, demographics. So it is going to be a big epidemic in our situation, and as intensivists, we need to look at it. And it's also possible that the patient will develop acute coronary syndromes while undergoing treatment for certain other conditions in the ICU, and we should have our eyes and ears open for these signs. As has been mentioned, it is not always ischemia that produces elevation of troponin. So, if somebody has had a toxic exposure, if somebody has had a trauma or a drug exposure, then you can still get the troponin elevation. How to discriminate it from a myocardial ischemia is going to be the crux of our of our competence and our skills in the intensive care. So it's an excellent presentation. Thank you all for joining us today. And if you have any queries or comments on this topic, please do post on the same group on which you got this link from, and we will try to answer them. We'll meet you again next week with another topic. See you all next week. Bye bye.
Thank you, sir.